Окей.
Нібито так.
Все хорошо. Расслабься, все хорошо.
Добрий день, шановні колеги.
Good afternoon, dear colleagues. So my name is I'm professor of surgery of Dnipro National Medical University, head of the urological department of medical base Molchanov Robert. And we are going to start our webinar, which is dedicated to the topics of the treatment, the diagnostics and prevention of the urolithiasis. So we do live in a complicated period of time when the brave Ukrainian people are fighting against the Russian invasion. Thanks to the enormous power of the army of Ukraine, the contribution of which are making us closer to the victory, and thanks to the support of the huge amount of partners, we may conduct this webinar. This webinar is conducted in the online format. We have 15 minutes for everybody to deliver their talks. In case you are going to have any kind of questions, please feel free to address them in chat. And we are going to start. The incidence regarding the urolithiasis depends on the climate, ethnic, nutritional factors. The incidence of the urolithiasis all over the world is from 1 up to 22%. And in Sweden, Canada, or United States of America, more than 10%. And the incidence regarding the urolithiasis in the regions of Ukraine is different from 25 up to 42.5%. And it is taking the second place among all urological diseases after the UTI infections. The interest to the urolithiasis as a topic is not going down because despite the development in science and technology, we know how to get rid of the concrements, but not how to treat the urolithiasis. Etiotrophic and pathogenetic principles sometimes are left besides the vision of the urologist. And war has led us to a huge migration and movement of the population. And also there were some questions regarding the urgent care to those soldiers which are fighting. And we do have some limited conditions, and new conditions require new approaches. So right now, I would like to give a floor to Professor Sergei Golovko, who is the head of the urology clinic of the National Military Medical Clinical Center, main military clinical hospital of the Ukrainian Ministry of Defense. Please, giving you the floor.
My name is Sergei Golovko. I'm professor of urology department, Bogomolets National Medical University, Kyiv, Ukraine, and former chief of urology clinic of National Military Medical Clinical Center, Main Military Clinical Hospital, Kyiv, Ukraine. And the theme of my report is urolithiasis in the military population. So, about 5 to 10% of the population in industrialized countries were known to having symptoms of urolithiasis in their lifetime. The prevalence rate of urinary stone disease has rapidly increased in the United States and European countries, as people in developed countries have been exposed to risk factors such as aging and metabolic syndrome. Kidney stones are a major problem affecting military personnel and may lead to decreases in individual and unit readiness. Little is known about the incidence of nephrolithiasis in the militaries worldwide. Soldiers must be kidney stone free and are often referred for treatment of small asymptomatic stones. Epidemiology of urinary stones in the French military. The French military sent to several operations are exposed to multiple contributing factors of urolithiasis as the dehydration and the strong temperature. The history of renal stone disease is the main factor favoring, and the medical treatment is effective in almost all renal colic cases. Renal colic was the most common urologic indication for air evacuation from the 47th Combat Support Hospital during the first 6 months of Operation Iraqi Freedom. Deployed personnel with urinary calculi can be appropriately and safely managed with an initial trial to conservative outpatient treatment. Also, computed tomography is a commonly standard for the diagnostic calculi. It can be replaced with alternative imaging techniques such as intravenous pyelography and plain film radiography of the abdomen, which are safe and sufficient to diagnose and initiate treatment for urolithiasis on the battlefield. And indication for evacuation from theater. Ureteral stones more than 4 millimeters, large renal stones, renal mass and stones, persistent renal insufficiency and stones, bilateral ureteral stones, ureteropelvic junction obstruction and stone, urinary tract infection or sepsis and ureteral stone, Baker Constable. So, treatment of urinary calculi in the combat zone. 86% of soldiers were successfully treated medically and returned to duty, preserving the fighting strengths of supported units. 14 of patients admitted to stone disease required intervention or evacuation. Some soldiers with complicated stones can be treated in the combat support hospitals and kept in the combat zone with the use of ureteral stents for selected patients. Many studies have confirmed that certain diseases are significantly more prevalent in veterans than in civilians. It was shown that a significantly higher proportion of the kidney stone group reported a history of military exposure than the non-kidney stone group, 17.6% versus 10.3%, p less than 0.001. In this large sample population-based study, it was found for the first time that military exposure was an independent risk factor for kidney stones, especially for men aged 56 to 69 years with a United States military background. There is a great need to be alert for the development of kidney stones. Urologic diseases in Korean military population. The incidence rate of this study was calculated from active duty soldiers who visited military hospitals with obvious symptoms from urolithiasis. Stone's occurrence was known to be lower before age 20, but peaks in incidence in age 30 to 50. Since higher body mass index increases chance of having urolithiasis, better physical fitness of military personnel might contribute on lowering incidence rate of urologic stone disease. And risk factors in patients in the combat zone. Undetected urinary calculi before deployment, reduced water intake, and increased perspiration, resulting in concentrated urine, increased sodium and protein contents in combat rations, high level of oxalate and caffeine consumption. Patients with combat-related injury present a high level of risk factors such as immobilization, hypercalciuria, permanent reclined position, which leads to the urinary retention or stasis with a following blockage. And diagnostic imaging modality include abdominal pelvic radiography, intravenous elography, computed tomography without contrast, ultrasound of kidneys and bladder, and nowadays the military medical service of Ukraine has received the portable ultrasound device that gives the possibility to detect small renal stones at the non-hospital stage. Conservative treatment is mostly initiated for patients with stones 4 millimeters or less in size, who could hydrate well and whose pain was controlled with oral medications. Size criteria was selected based on published rates of spontaneous stone passage, intravenous or oral hydration, pain control, narcotics, and the non-steroidal inflammatory agents, treatment for constipation, antiemetics, and we use a broad-spectrum antimicrobial regimen for empiric therapy of patients with acute complicated urinary tract infection who are critically ill to prevent the increasing prevalence of multi-drug resistant organisms in the mobile hospitals and clinics. Medical expulsive therapy include alpha blockers, ureteral stones more than 5 millimeters and less than 10 millimeter in diameter, tamsulosin, 0.4 milligram once a day for up to 4 weeks to facilitate spontaneous stone passage. Usage of terazazine, doxazazine, alphazazine, or silodazine is also reasonable. Calcium channel blockers, nifedipine, has also been shown to facilitate stone passage, but it used less commonly. Other agents, in addition to alpha blockers and calcium channel blockers, a phosphodiesterase type 5 inhibitor has been used alone or in combination with tamsulosin as medical expulsive therapy. Patients with concomitant sepsis and azotemia unresponsible to vigorous fluid resuscitation are needed cystoscopy, ureteral stent placement, or evacuation for definite urologic management. In summary, the soldiers sent to the military operations are exposed to multiple contributing factors of urolithiasis as dehydration, strong temperature, post-traumatic condition, etc. Only a few studies reported about the incidence of urolithiasis in militaries, with no data available about kidney stones in battle-related injuries. As war in Ukraine still goes on, it prepares big difficulties in investigating urolithiasis in Ukrainian soldiers as well. This calls to further studies to find any significant difference and contributing factors of the urologic disease in the armed forces of Ukraine. A creation of patient database presenting to the combat support hospitals with urolithiasis is still required. Thank you for your attention.
Дякую, Сергій Вікторович.
Thanks a lot. Could you tell us? We have a couple of questions. So at this moment of time, you have provided some data which are used among some other countries. So could you tell us whether in the full amount all of those measures are implemented among our soldiers, among our military officers, and in general, how exactly the support of our foreign colleagues, how does it influence the providing care to our warriors? Yeah, thanks a lot. Our medical service and actually the surgical service, it actually contributes and fights well with different difficulties which appear at the different stages of the medical evacuation. We have the proper equipment, which is extremely important, but support, the constant support from sponsors, from foreign countries, it also has its own meaning, and it gives us the possibility to provide a higher quality care. Thanks.
Говорити про ці запитання. А зараз ми
And
переходимо.
right now we are going to move to the next talk. And we are going to talk about the individual approach to the complex treatment of patients with urolithiasis and with the topics regarding the prevention of its recurrence. We would like to invite Konstantin Barannikov, the assistant of urology of Dnipro National Medical Academy. Please.
Добрий день, колеги.
Good afternoon, dear colleagues. I would like to introduce my topic regarding the individual and complex approach regarding the treatment and diagnostics of patients with urolithiasis and the prevention of its recurrence. So the urolithiasis, that's a rather complicated pathological disease, and there are quite a lot of metabolic issues, as a result of which we have complements which are being formed. Usually that's the individual changes which are rather specific for each microorganisms, and it makes it more complicated to treat this disease. And we do not have one approach to the urolithiasis, which of course slows down the effective treatment of urolithiasis. There are different kinds of series which explain different steps which lead to the formation of kidney stones. The high percentage of recurrence of the disease makes it necessary to determine the risk factors of various types of CKD and accordingly individual selection of the effective approaches to the treatment schemes and prevention. To decrease the amount of recurrences, that's the main approach which is needed to be done to reduce the costs in order to treat the patients with urolithiasis. So the diagnostics approach starts with the screening questionnaire, then to find out the comorbidities, finding out the water intake and nutrition, then standard laboratory examination, ultrasound diagnostics, CT, which is the golden standard in terms of the diagnostics. Then by using the CT, we identify the characteristics of the stone, the size, the placement, and also the density. But we do not have enough data regarding the Hounsfield density and the presence. That's why we need to identify the index of the density, which is needed to be identified, which is going to influence further on. Also, we need to identify the indicators of heterogeneity of the structure, which gives us the possibility to identify the most effective approaches to treat. Also, we need to prevent all the other unwanted comorbidities in order to prevent any kind of other further development of the disease. One of the ways how we may identify that's the analysis of different factors which lead to the development or the formation of the stone. We also need to know about the data regarding the structure of the stone, which first of all are needed to be identified in order to know the physical structure. As an example, carbon has different kind of forms, but the density of the structures which consist out of the carbon, they are different. The structure and texture, it is something which defines the density of the kidney, the space of the kidney, the wholeness of the kidney. And we need to know all of those indicators in order to know how to destroy the kidney. Different kind of kidneys have different kind of structures. The bigger and the smaller structures, and the smaller ones have a better approaches to be destroyed. The complex approach to the diagnostics of the urolithiasis, it opens us possibilities to have an individual approach to the prevention and treatment of the recurrences. So here are some of the modern approaches to the treatment among the patients with urolithiasis. And it gives us the possibility to have the individual treatment and prevention of recurrences in order to improve the compensatory reactions and also to recover the state of the kidneys. We are not going to talk about the drug treatment of the urolithiasis, but we need to mention the presence of some of the drugs which might help us at the different stages of the urolithiasis treatment. One of the most common drugs which is used around the world is cannifron, and cannifron influences on the different stage of the formation of the concrements, and it might be used depending on the structure and of the concrements in order to increase the efficacy of the concrement destroying procedures and also to have the meta prevention of the recurrent of the urolithiasis. And that is the safe way to use this drug, which is proven. So the existing standards of treatment, they give us the idea about the structure of the concrement, and it should be done separately for each patient. We need to know the mechanism of the formation of the stones. We need to find out the more targeted approaches to the urolithosis and also to use the lithotripsy effectively. And we need to identify the individual schemes of the prevention of the recurrence, which is important in order to have the next further studies to be done in order to be more efficient. Thanks a lot for your attention.
Так, ще не побачила. Вже побачили. Угу. Все? Так. Дякую, Константин Сергійович, за цікаву
Thanks a lot,
доповідь.
Konstantin, for this interesting presentation. We hope that some of the questions are going to appear later on. I'd like to repeat once again that please you may send us the questions in the chat of the webinar. And right now we are going to move further to another topic. As it was already mentioned by Konstantin, we have a huge amount of different kind of trials which we use, or different kind of investigation approaches which are needed to be conducted among the patients with urolithiasis. And we are talking not only about the diagnostics of stones in general, as we need to excise, or in general the diagnostics of the disease, which is the underlying condition which leads to the formation of the concrements, because we do know that concrements, that's a symptom, that's the complication of the disease itself. And the huge meaning and the huge importance of diagnostics of those diseases are done by the laboratory diagnostics. And that's why our next speaker, Vasil Sukhey, Deputy Chief of the Medical Plaza Center, Deputy Chief regarding the diagnostics, is going to deliver his topic regarding the laboratory diagnostics of the urolithiasis. Please, Vasil, giving you the floor.
Після того, як виникла ідея
So after the idea appeared around the complex diagnostics of patients which have urolithiasis or which have the suspicion of the urolithiasis, we have studied after that the whole literature which is available at this moment of time. And we have identified the most proven from the evidence-based point of view factors which contribute and which are the part of the list of the laboratory assessment. Besides that, we have developed pre-analytic note for patients, how exactly they need to prepare themselves correctly in order to get those analyses done. I mean the analysis of blood samples and urine samples. So you may see the list of the analysis which are needed to be done and performed among the patients with urolithiasis. We have over here those indicators which give us the idea to have a better understanding at which moment of time did the disbalance appear. So is there an issue with metabolism as a result of which the concrements started to be informed, the concrements in the urinary tract started to form.
Крім того,
Besides that, as an addition to that, during the analysis of daily urine, we have identified the cations and anions which are responsible for the concrements formation These are the phosphate anions, citrate anions, urate, and also cysteine and oxalates and cysteine, which might also form the concrements, the cysteine concrements, and also the cations, which are the basis for the stone, like the sodium, calcium, and magnesium. Besides that, we have also performed, and of course we usually perform, the bacteriological urine culture and also the culture of feces regarding the dysbiosis. So the main aim of all of our laboratory analysis is to identify and to determine the causes of the development of the urolithiasis, to identify in which parts of the chain of metabolism we have disorders, so to determine the metabolic disorders, and despite that, also to perform the analysis in order for surgeons to choose the best possible surgical intervention in each separate case individually. And despite that, despite all of that kind of trials and all of that kind of laboratory researches, it gives us the possibility to determine the optimal prevention and treatment of urolithiasis, which is extremely important in terms of the urolithiasis as a disease. Thanks a lot. Yes, Vasil, please take a seat. We still do have some kind of questions over here. So, you have delivered us information about rather huge panel of analysis, which we need to perform for patients with the urinary tract urolithiatic disease. I know that in terms of the medical plaza, we may provide all of that. Could you tell me, could it be done and could it be conducted also in other institutions of the healthcare facilities, in order for that to be formed in their routine practice as a routine analysis, or we need to have a proper centralization or some kind of medical care additionally? What do you think about that? So when we have developed this kind of complex, we had a couple of additional machines which were procured, like the spectrometry analysis machine which was procured, and also some additional machines like vortex machine and so on and so on. So in general, each laboratory, in case they want to, they might do it and they might learn how to do it, but they need to invest, of course, some finances in order to have the proper equipment. We have identified the idea and we have financed all of that, and we need to have the proper investigations to be performed. So usually it takes up to 2 days in order to get the results after the sample collection. And I think that all of that might have been done in a centralized way. I do not know any other laboratories in our city which would perform all of those investigations. In some laboratories, you may perform some part of those analyses, but that kind of as a complex is not conducted. Besides that, the identification, for example, of oxalates in the urine or citrates rates in the urine, that is something which requires the imported foreign toolkits, and we order those toolkits separately. And in case that is something that is going to be done not that often in the laboratory, it is going to cost much more. So it's going to be an issue. So what we did, we decreased the cost of those kind of analysis by doing that. Thanks a lot for your interesting topic. And we are going to continue further on. So we have talked right now about our laboratory analysis, those kind of analysis which are needed to be performed and which should have been performed in any kind of medical center. I mean, in the Ukraine. But right now, I would like to invite our foreign colleague, Dr. Harry Whitwell, who is going to deliver his talk regarding the other way to perform the analysis. We know that at this moment of time, we have some approaches which allow us not only to identify the presence of the diseases by using the laboratory analysis, but also that is the analysis which allows us to identify the genetic factors or the presence of some kind of specific processes which are happening. I mean, the analysis of the structure of the stone on its own. Also, to identify the changes in the synthesis of the proteins which leads to the disease. And we are talking about the analysis of proteome, about the proton analysis, which might be performed among those people which suffer because of the urolithiasis disease. During the last period of time, we do have a lot of different publications regarding the proteome analysis among the patients which have urolithiasis. And at this moment of time, it's time to implement those kind of investigations. But I'm not going to take too much information from our speaker. Let's just listen to him how exactly this kind of analysis looks like. I mean the proteome analysis. Please, Dr. Harry Whitwell, Proteomics Platform Lead, Imperial College of London. Please, giving you the floor. In case you could hear me, it means it works fine. In case you do, I hope you can hear me. Thanks a lot. That's great that you could hear me. My name is Sava, going to be your interpreter during today's session, as far as I assume. So we are waiting right now, as far as I understood, the talk of the Dr. Vitika.
My name is Dr. Harry Whitwell, and I work at Imperial College London in the National Phenome Centre. And I wanted to tell you a little bit about some work we do in high throughput blood proteomics and some of the aims of our centre, and then perhaps a quick example of some of the applications of that data. Okay, so like I say, I work at the National Phenome Centre in Imperial College. The aim of that centre is to do phenotypic analysis, by which we mean we take a sample and we measure small molecule metabolites, lipids, and proteins through an array of platforms based on mass spectrometry and NMR. And the aim there is to really identify what proteins or molecules are different in disease states. And then we also have within our institute a large genomic facility. So we're able to really characterize a huge amount of molecular differences between different diseases or samples from different diseases. Now, 2.5 years ago, I was employed here to bring proteomic capabilities into that centre. And at the moment, the way we operate is that a sample comes in and we can do that. You can take that sample and do a simultaneous sample prep for either our small molecule or our lipid analysis. Unfortunately, we have to take a separate sample set to go through our proteomic pipeline. And really what we want to move towards is taking a single sample and be able to do a single extraction and then be able to push that sample through our different pipeline or different sample modality. And that's something that we are moving towards. And part of this work that I'll show you is helping to move in that direction. So briefly mention why proteomics, because a lot of people say, why not just transcriptomics? Because the advantages of transcriptomics are that the sensitivity and the coverage are excellent. If you don't have much material to begin with, you can make more through rounds of PCR, and you can quantify all of those relatively straightforwardly and get really good depth of coverage. So you can identify lots and lots of different transcripts. In proteins, we have a limited amount. Whatever we have given from a sample is what we have to analyze. We can't make more of it. But the main take home from this slide here is this plot C here, which shows the correlations between proteins and their mRNA. And you can see that there's very little or no correlation between those two related molecules, which means that if you measure the transcript, you're not necessarily measuring what is actually phenotypically important to knowing what the cell is doing. So you may see changes in some transcript, but that's not translated up to the protein level, then there's not necessarily a clinical manifestation of that genetic change or change in gene expression. And that's really what's important. And that's why it's important to look at the protein level. This plot on the right gives some further examples as to proteins and transcripts that don't correlate very well. So when I say we do proteomics, we use a technique called mass spectrometry. And the advantages of this is that we can identify many, many hundreds of thousands of proteins in one go, and whether or not they've been modified chemically. So it's a very powerful approach. And we call it bottom-up proteomics. It's a bit similar to sort of shotgun genome sequencing in that we take our protein mixture and we chop all of the proteins up using an enzyme that cuts at cuts at a predictable site. And that cuts everything up to a length that's much easier or more straightforward for us to analyze and get good depth of coverage and quantification on. The first step of that is obviously extracting some proteins, and wherever, largely in the body, wherever there's proteins, we can extract those proteins out. And once that extraction has taken place, actually the downstream processes are basically the same for whatever ever sample type. And that is that we need to cut those proteins up. Normally we use an enzyme called trypsin. And then we do some mass spec analysis. And historically, that's taken 60 minutes to sort of 3 hours per sample to get good coverage. And some of the innovations now coming out of various vendors and mass spec companies is really aimed at reducing that time onto a more higher throughput level, which is far more cost effective, whilst maintaining the same level of sensitivity and quantitative accuracy. So once we've done some MS analysis, some mass spec analysis, we then have to identify all the peptides that are present, which we use a suite of tools, of softwares, depending on the application or the method, the biological question. And then we infer what proteins are present from those peptides. And we can do that from looking at a database similar to shotgun sequencing. So we take all of the peptide, we take the identified peptide and have a look, okay, so it will have come from this protein, looking at the protein sequences. And then at the end of that, we get essentially a list of proteins and their relative expression. And for a simple matrix, such as tissue or a cell lysate, we may expect to see maybe 5,000 proteins in a fairly short space of time, in maybe a 20-minute run from our system. We can also look at serum and plasma, which is a more complicated matrix, and it's complicated because the dynamic range of protein expression within serum is enormous. It covers about 10 orders of magnitude. The most abundant few proteins, which account for the vast majority of the biomass or the protein mass within serum, so maybe the top 5% are only 10 or 20 proteins. And the problem there is that you need an instrument that's technically capable of maybe visualizing the whole world and counting grains of sand. That's the order of magnitude that you need to accomplish, and that's not technically possible at the moment. So there are ways to remove those top few proteins in order to get deeper coverage, moving more towards the 5,000, but that comes at a cost of quantitative accuracy and throughput. So we tend to sort of say, well, we can keep the throughput good, we can keep the quantitation good, but we may only be identifying the top most abundant proteins. But, and I'll show you in a moment, there's a lot of clinically relevant information that's captured within those top 300 proteins. And we can do this in a very cost-effective, and we can do this analysis in a very cost-effective manner.
So this instrument here from SciEx, and there's a little bit of a caveat here in that they've actually lent us this instrument in order to do some method testing. So there's maybe a slight conflict of interest. But for us, this has been a really great addition to our portfolio. Firstly, the cost of the instrument. Okay, it's been free for us for a short amount of time, but we are looking to buy this. The cost of it is very good and much cheaper than some other top of the range instrumentation, but they've been able to do that without keep those costs low without sacrificing sensitivity and mass accuracy, which is very important. So secondly, sensitivity is very good, which is giving us lots of protein identifications and good quantification. And thirdly, the mass stability is excellent. So I'll show you some example data in a moment where we've identified hundreds of samples with a very stable mass accuracy and a very stable sensitivity throughout the entire run, which means that we can support the analysis of very large cohorts. And finally, the scan speed is very high, which means that we can reduce our run times down from 60 minutes plus down to the same scale as our small molecule analysis. Now, our small molecule analysis is working on a runtime of about 14 minutes per sample, whereas our MS historically has been 60 minutes and longer. So bringing that down onto the space of 14 minutes means that we can now better move towards providing a more comprehensive omics analysis of large studies. So before, if we took a sample and we were doing 14 minutes small molecule analysis, but it was taking an hour per sample proteomics, we've got a large bottleneck. So we're eliminating a lot of that bottleneck thanks to this instrument. So here's just an example of some of the data, and this is some mouse plasma proteomics. We identified quantified, I should say, about 250 proteins. And what we have in this setup is we have a study reference, which is a pooled reference sample from all of our study samples, and we run that intermittently throughout the run. We have our study samples, and then we have two other reference samples, which are made from another study. And the first point is this blue line here, which is our reference sample, that the stability of the signal, and this is non-normalized data. Sorry, this is normalized data. Is very good throughout the entire run. So I think in this study we had about 35 study samples plus our references spaced intermittently during the run. So about 60 samples overall. And we had very good linearity. And then what we also do at the beginning and end is run a dilution series of the study reference sample. And this tells us two things. Firstly, we run it at the beginning. That's what this orange line is. And we can see that we have a good dynamic range of quantitation. So we're getting a response from the instrument. Continue to get it's not plateauing yet, although it will be soon, so we're near the top end here. Secondly, that the CVs here between 3 technical repeats are very good, so we've got very low error bars. And then secondly, we run this dilution series at the end. And what we observed, really pleasingly for us, is that those two dilution series map perfectly onto each other, which means that throughout that runtime, we've not actually lost any quantitative ability, which means that that system, the instrument itself, has been very stable. We have a quick look at CVs. We see our study reference samples, a median CV of less than 10. So that's all the proteins identified with the median, have a median CV of less than 10, with a few outliers, and a slightly higher median CV of about 30% for our biological sample. And again, you see this mirrored in this PCA plot. So we have we have most of the variants in the PCA plot being describing the biological variants from our study sample, and very tight clustering of our study reference sample right in the middle of those study samples. So really nice looking PCA plot for us. Secondly, an example is this human plasma proteomics, and this is quite a naive data set. I've only just got this. So what we have in the blue line here is, sorry, both of these data sets are unpublished, so I can't give too much information about them. But this one's from human blood. And again, we see that we have our study and our study samples, study reference, and a separate project reference. So that's a reference sample, a reference sample that's not made from this study. And again, in our green line here, which is our study reference, we have, and our red line there, which is the alternative reference sample, we have really good stability across the entire runtime. And this cohort, we had more samples, about 150. 150 samples overall, and really good stability of the system throughout the entire runtime. We also had 3 batches, so these are prepared at 96 well plates, and we had 3 of them. And you can see again that we've got really good stability. So actually, I think there's about 250 samples in this one. You have really good or limited batch differences between these 3 samples. So the data looks really, really nice. Okay, so I said that we only identifying 300 proteins, but those are still useful. So here's just an example of some prediction models that we built using some of these proteins. We didn't actually acquire this data, but this was a project that I was involved in with Professor Alexis Aiken, Dr. Oleg Blius, and Dr. Tatiana Nazarenko. And what we do is we construct a network-based predictive model to predict whether or not somebody had an adverse outcome following a COVID-19 infection. And we were able to do this very well based on proteomics data acquired using very similar methods by Marcus Ralser and Vadim Demichev's group at Charité.
Дякую, Гаррі, за
Thanks a
дуже
lot, Harry. Thanks a lot for this great talk. And we do understand that this is extremely great and perspective approach to evaluate the patients. It's a complicated approach, and we need to have additional time in order to take a look into that. We need to pay more attention to this. And also, we need to try to implement this approach into our today's reality. And we would like to thank you, Dr. Whitwell, for his great talk. Which is not just an information for us, but it's also the support of our further action. And I hope that further on we are going to continue our cooperation, and we are going to continue our cooperation not only from the point of view of the lectures, but also we are going to cooperate from the scientific point of view. And I think that is going to be an interesting cooperation which might happen. But when we talk about different kind of massives of data, which we obtain thanks to these methods, for example, so the laboratory data which we obtain, there are some situations and results when we need to use also the statistics and mathematic models, because without this kind of science, we cannot move forward. And you have seen in the presentation the statistics, data, and results, which will evaluate by using the statistics methods. And the modern physician, the modern scientists, they need to know the statistics models in order to know how exactly the data were obtained in different kind of publications, trials, in the modern trials, and how exactly we need to pay attention to all of that. How to identify the real publications with real results which were analyzed properly, which propose you effective approaches, comparing to the ineffective approaches. And that's why the next talk is going to be delivered by Oleg Blius, Associate Professor of Institute of Population Health in the Queen Mary University of London, United Kingdom. And Oleg Blius is a specialist from the statistics point of view. Please, Oleg, we kindly invite you to participate in this topic.
Hello to all the participants of the webinar. Thank you very much for the opportunity to make this presentation today. My name is Dr. Oleg Blius. I'm a reader in data science and statistics at Queen Mary University of London and University College London. And today I would like to talk about the development of predictive models in medicine. For most medical applications, the outcome of interest is binary. When dealing with any specific medical condition, we usually want to classify patients into those having a condition, who we also call cases, and those not having, who we usually call controls. Sometimes there are exceptions. We may wish to make multi-class predictions where we want to stratify our patients into numerous classes. For these purposes, there are different approaches, but today we'll just focus on the simplest and the most common type of the problem where the outcome is binary. When the outcome is binary, predictions are probabilistic expressions. So those are probabilities of having this specific condition. And they're usually expressed either as regression coefficients, if a specific regression model has been used. This could be odds ratios, like with the logistic regression model, we interpret those coefficients in terms of odds ratios. Or maybe hazard ratios, that's when we also got time variable introduced, like when we're trying to deal with time to death or time to lapse, etc. Here are the steps to model development that we will talk about today in brief. We'll start with problem definition, data inspection, then we'll discuss how to code the predictors, those variables that we want to use in order to be able to predict the outcome. We'll proceed to model specification, model estimation, model performance, model validity, and finally, model presentation. So we'll start with the problem definition. The preliminary steps before we start any modeling include, of course, formulating the research question. What's that we are trying to address? Then we put together information about predictors. So these are all the parameters that we want to include into modeling because we somehow anticipate they may be related to the outcome of interest. Of course, it's analyzing the reliability and completeness of the data. The data has to be reliable, it has to be complete in order for us to be able to proceed to the modeling. If the data is not complete, most of the methods simply will not be able to produce the results we hope, etc. So with regards to coding of predictors, most of the variables that we are dealing with, they are either categorical or continuous. Categorical means though they express not as numbers, but as categories. This could be some simple categorical variables like gender, that could be male and female. Why I call this simple? Because we only have two possible options, in which case we can, for example, assign 0 to one of them and 1 to another. And as a result, this new produced variable is called dummy. Dummy means it's binary, it's either 0 or 1. However, when a categorical variable contains more than two levels or more than two categories, the way they're transformed with any software is they're automatically transformed into dummy variables. Say we're talking about smoking, and we may consider three possible options like never smoke, current smoker, or used to smoke. Then the way it will be categorized and analyzed is we use one of the levels as a reference, like never smoke is the reference. And then we'll introduce two dummy variables, where one would be smoker versus never smoke, and another would be used to smoke versus never smoke. As a result, with these two dummy variables, we will be able to code any patient, whichever category they belong to. When talking about continuous variables, there's multiple approaches that can be used to include such variables, and it depends on what predictor represents. There's this interesting paper by Grunwald published in 2013 where they considered different options of adjusting for age, continuous confounder, basically different options of how to incorporate this continuous parameter into the model. And their results were expressed as odds ratios. And basically the methods that they considered were crude. Crude means we just include age as it is. Dichotomized, where we introduce a cutoff and then everything below is 0, everything above is 1. 5 categories, where we just categorize age into 5 groups. Some linear function of age, and some more sophisticated approaches like fractional polynomials, restricted cubic splines. And what they have shown is that depending on this transformation, we may actually get different results. And some of them may actually be statistically significant. Like in here, for example, with the last approach, restricted cubic splines, they achieved statistically significant odds ratio between smoking and cardiovascular death when adjusted for age. Now coming to model specification, there are multiple strategies how to choose predictors. So which predictors do we include in the prediction model? Most used strategy is stepwise selection with inclusion of interaction and nonlinear terms, where we simply add new variables. So we may start with one predictor and then we try out including other predictors. And at each step, we check if model performs better, basically. And as a result, we end up with the optimal kind of set of predictors. We may do it the opposite. We may start with including all the possible predictors together and then just trying to exclude any one of them and see how it affects the performance. Predictor selection, it's important, should usually consider clinical knowledge and previous studies rather than statistical methods only. So we cannot just rely on statistics. Of course, it's really important to make use of expert opinions. Coming to model estimation, so model coefficients, like in logistic regression, that's one of the most commonly used predictive model. They're commonly estimated with the so-called maximum likelihood methods. So those are the mathematical methods that allow us to obtain the optimal model given our data. We specify the model, and then given our data, we may find the optimal parameters, which are simply regression coefficients. To prevent overfitting, there are some statistical techniques such as ridge, lasso, and elastic net. We won't talk about that in this presentation, but it's important to be aware of them. And that's something to consider when there's any reason to believe we may be overfitting. Like when we have too many predictors, which we are trying to include, while the sample size is very limited. Coming to model performance, there's multiple measures that allow us to assess the performance of a model. This could be overall performance, discrimination, calibration, reclassification, clinical usefulness. So overall performance may be, for example, accuracy. How accurate our model is, which is just one single number that reflects the quality of the classification of our patients into two groups. Discrimination deals with how well we separate, how well we distinguish the two classes. And the most commonly used parameter to assess discrimination is the area under the ROC curve. So we are able to construct the ROC curve and find the area under the ROC curve. And it really does tell us how well the classes are separated. If they're perfectly separated, if the model allows us to perfectly distinguish cases from controls, the area under the ROC curve would be 1. Most of the time it's not perfect, it's below 1, and then depending on this value, we're able to say if the discrimination is good or not. Calibration tells us how well the probabilities produced by our model reflect the true probability of having a condition. So the model is called well calibrated if when a model gives probability of having a disease to a specific patient, let's say 0.8, it implies that if we take 100 patients with the same characteristics as this one, 80% of them will have a disease, 20 will not. That means model is well calibrated. There are two more things that are sometimes considered when talking about the performance. These are reclassification, and there's net reclassification improvement and integrated discrimination improvement, and clinical usefulness. Clinical usefulness is usually expressed in terms of net benefit or decision curve analysis. Again, we won't dive too much into that, but these are the things to bear in mind when assessing the quality, the performance of a predictive model. And there's this plot, the biopsy example, where there's multiple strategies, and then we may play with threshold probability to find the net benefit that, so basically at each threshold probability, we may find a model, a strategy for the biopsy that would provide us highest net benefit. Now coming to model validity. Once the model is defined, we want to actually find out if it's valid or not. There are two ways. It's either internal validation, where we are trying to validate the model with the same data, or external validation with the external data. Of course, the latter is preferred, but most of the time we have to deal with the internal validation. And this table provides a number of approaches that are commonly used for the internal validation. This may be apparent. Apparent means we train and test on the same data set. That's a biased way of assessing that. We sometimes may, for example, split our data into, say, 50 and 50%, and then just train on one half, test on another half. There's also cross-validation approaches that are very commonly used, where we divide our data into a number of folds, and then say 5. And then we train our model on 4 and test on the 5th. And then we do that for each out of 5 and average the performance. This gives us some average unbiased estimate of the performance of the model. There's also a number of bootstrap approaches existing for these purposes. Finally, model presentation. So regression or any other formula, that's a common way of presentation, the model that we've implemented and developed. Often, sometimes some score charts and nomograms are used because they are easy to use alternatives. And of course, most recently, people tend to use web-based calculators or apps for mobile phones, where you can simply feed the information and just get the results as a risk or possibly just binary classification, or both. Here's the list of references that I have used for this presentation. Thank you very much for your attention, and thanks for inviting me to make this presentation.
Thank you very much for your excellent presentation. And I would say it's not only a presentation, I would say that it's a state-of-art lecture. And I think all scientists who start to work with the statistic or mathematics should listen to this lecture so that understand what we should start from, because this really step-by-step instruction, what should we do, what should we wait for, and other things which are very important in any research. And I would say it's like a guidance. I think maybe a short variant can be printed as for decision of our presenter, Oleg Blues. Thank you very much. Ще раз наголошую, будь ласка.
I'm going to emphasize once again, dear colleagues, please send your questions, in case you have any of those, in our chat, and you are going to have those answers from our speakers. And right now we are going to switch to our next talk. And our next talk is going to be delivered by Valery Ishkov, who is the candidate of biological sciences, associate professor, the senior scientific scientist of the Institute of Geotechnic Mechanics of the National Academy of Sciences of Ukraine in Dnipro Polytechnic University, who is going to deliver his talk regarding some features of the mineral composition and structures of uroliths. Please, Valery, giving you the floor. So the study of uroliths using an arsenal of mineralogy and petrography methods was started in the beginning of the 20th century. Right now, we have actually a 100-year anniversary from that event. For the first time in 1922, Nakano, and in 1923, Kaiser, after making thin sections of urinary stones and studying them in the polarized light according to the classical technique of the petrographic analysis, they described cystine and crystals of aqueous calcium oxalates. On this slide, you might see some features of the mineral composition of uroliths, which I was studying. The vast majority of uroliths are polymineral formations. And then there is a question, monominerals, is it an exception or an imperfection of analysis methods? The distribution of various mineral species in space is highly uneven. Unlike analogs or other mineral phases of geological objects, urolith crystals are exceptionally defective at various scale levels. Minerals that are part of uroliths always contain non-uniformly distributed inclusions of the organic matrix of different scales and degrees of organization, and sometimes of varying composition. Further on the slides, we will see the illustrations of all of that. On this slide, you may see the huge composites of hydroxyphosphate, which is an amorphous variety of hydroxyapatite, rosin of isometric form surrounded by calcium oxalate monohydrate, polarized light magnification 80. On the next slide, what we might see the central part or the core of the pseudo-oolitic aggregate of calcium oxalate dihydrate, which is composed of an amorphous type of phosphate, hydroxyapatite, saturated with the smallest inclusions of exotic organics of red color. It differs from other organic structures. A layer of uric acid dihydrate is observed along the perimeter of the central part. In the next slide, we may see splitting of uric acid crystals with numerous inclusions of organic matrix and xanthine. On the next slide, we might see the cleavage of uric acid dihydrate crystals with numerous inclusions of organic matrix and xanthine as well. Moving on. Regarding the structures of the uroliths and their peculiarities which I've been studying. There's a druze-like structure, a spheroid structure with a concentric zonal and radial structure. That's the lumpy structure and so-called combinatorial structure. For all types of structures, there is always so-called core or central area, which differs by its mineral composition. On the next slides, you might see some pictures of those positions. You may see the spheroid structure of urolith. Light is transmitted, never crossed. And the light is something that allows us to see a concentric zonal and radial radiation structure. Accumulation of organic matrix is visible in the central part, or so how it is called core of the aggregate. And also, we observe some local areas or pockets, which are also called organic concentrations, which are observed on the periphery as well. On the next slide, we do see a great example of the druze-like structure of urolith. On the next slide, you see the zonal structure of the urinary stone, of the kidney-shaped aggregate, which consists out of the several spheroids. On the next slide, we might see so-called combined structure of the uroliths. Moving on, we do see a great example of this combination structure. And on the next slide, we might see the central part of the urolith of oxalate composition, which consists of an accumulation of organic matrix impregnated with highly dispersed crystals. And next, let's move to the conclusions. In the samples of uroliths studied by me, we have spheroids and drusen aggregates, which are the most common found one. The presence of 15 mineral species was established the composition of kidney stones by optical petrography methods with the predominance of oxalate and urate compounds. And monomineral accumulations were occurring in less than 1%. The central core part of uroliths is usually represented by the accumulations of organic matter containing a highly dispersed mineral component. A characteristic feature of all mineral individuals, without exception, is their multi-scale microblocks variety and the presence of inclusions of organic matter. According to my opinion, the mineral and organic components of uroliths are equivalent in the process of formation of composites. According to my opinion, only the mineral and structural features of the nuclear part, they are the most informative for establishing the causes of the disease. Only a complex of large-scale studies, which includes morphological analysis of the sample and a spectrographic study aimed at identifying structural features and mineral composition of uroliths, allows us to confidently establish the main regularities of its ontogenesis. And according to my opinion, solving the problem of urolithiasis is an interdisciplinary task. First of all, it is the field of medicine, mineralogy, chemistry, and physics. And in the end, I would like to provide you this kind of summary that outdated ideas about the mineral composition and structure of urinary stones, they significantly inhibit the solution of the general problem regarding the formation of those concrements. At this moment of time, I would like to finalize my talk. Thanks a lot for your attention. Thanks a lot, Valery. Thanks a lot for this great talk. And when we see all of those crystals, then immediately we start to understand why not all of the guidelines on which we use at this moment of time, why they are really acting. We all know, for example, that when we plan our lithotripsy, distant lithotripsy, one of the important indicators, that's the Hounsfield indicator, so the density of the concrement. And we start to talk that in case the kidney stone is not that dense, and in case it is dense, it is not that good to perform the lithotripsy, but the practice shows that no. And right now, we had an opportunity to take a look closer how exactly the structure of the stone changes depending on the organics and depending on the non-organic component. We do understand that the higher the part of the organic is there, non-organic, then the more dense the structure is. And in case we have less non-organic and more organic structures, then it's less dense. And we need to understand that less dense stones, concrements, they might be destroyed easier. But in the last case, there are some conditions when we need to recommend how exactly to perform the lithotripsy depending on the composition of the stone. It might be compared with carbon and diamond. Carbon is everywhere, but diamond, you know that it is rather dense. But graphite, I mean the one which we have in our pencils, it might crush easily. And right now, let's move to our next stop. And our next talk is also regarding an important topic, how exactly we perform the analysis which should be done when we talk about the adequate treatment of our patients, about the meta prevention. Without this analysis, we cannot move forward. And we are going to talk about infrared spectrometry. And the talk is going to be delivered by Alexander Balalayev, candidate of the medical sciences, the senior medical professional of the Geotechnic Institute named after Polyakov in Dnipro. Please, Alexander, giving you the floor. So, the incidence of urolithiasis is growing all over the world, and it requires definitive information to know the types of the kidney stones, and they depend on the etiological factors, genetic factors, and also they are rather specific for each one of the patients. The modern mid-FTIR, so the mid-infrared spectroscopy, gives us the possibility to evaluate all of those indicators by performing the proper analysis. And it shows us the quantitative information in the molecular component or the molecular compounds. And it gives us the possibility to use appropriate standards. MID spectroscopy gives us the possibility to identify the proper structures of the concrements. Those concrements which cannot be destroyed, they might be identified, and we may use the spectroscopy in order to identify the presence of different kind of compounds in gases, in hard materials, and so on and so on. In the University College of London, the meta-analysis was performed where the quantity and where the composites were identified. We may see that more than 500 up to 4,000 samples were performed, and among those laboratories which used FTIR spectroscopy, they had the possibility to show more than 90% of the accuracy. And that was the analysis of the rare and also most common kidney stones. And the polarization microscopy is the only method which might be a competitor to the FTIR spectroscopy, but it has some certain limitations. For example, the sample might be destroyed during the evaluation, and it requires a huge amount of material in order to get a proper analysis. And the second approach, the microscopy, it requires a long term to prepare the material, and there is no possibility to identify the results in the small amount of the sample, and also the results are also subjective. The other method of the structure evaluation, the X-ray diffraction, it has shown the low sensitivity, less than 60%, which is much lower than the evaluation of the FTIR spectroscopy. The reason for that is how exactly the X-ray is used among the crystallic form of most of the kidneys. Most of the concrements, they have the oxalates of calcium or combination with phosphates or urine acid. And oxalate of calcium might be crystallized in two different crystallized forms: monohydrate and dihydrate form. And all of those stones, they are not transparent for the X-ray beams. And all of those organic structures like protein, they are transparent. And FTIR spectroscopy does not have that kind of limitation, which gives us the idea to perform this evaluation for all different kind of mineral and non-mineral molecules. And that's important in order to perform the molecular analysis of the concrements, because in the process of formation of the concrements, organic and non-organic substances might take place. So the change of the dipole moment of the molecule during the movement of the atom, it leads to the bending vibrations. And there are three types of the bending vibrations: valent changes and also the stretching vibrations. So there are two types of vibrations which might be done in a plane or not in the plane. And there are different types over here. There are different types of vibrations which depend on the length of the wave, and they form a proper spectra. For heteronuclear connections, there is a different kind of changes in planes and out of planes. For kidney stones, we have OH, CO, CNO connections, and others as well, which are the part of the mineral components of the structure. At same moment of time, presence of different kind of vibrations, it helps us to identify its functional group. Methods for recording FTIR spectra might be used depending on the transmission mode in case of the drift, by using the profile spectroscopy tools. So in case we talk about the IR source, it might get through the detector by using the pellet containing sample. And then the FTIR spectroscopy depends on the detector and internal reflection element. So the negative points regarding that it takes quite a long period of time to prepare to perform this analysis. And the main thing around the drift method, that's the possibility to get the spectra from the small small sandy-like structures and having a good results regarding the noise and signal. And we have a limitation regarding the need of a huge amount of the material and the possible presence of some changes of the spectral wideness. And those kind of artifacts, they deliver additional information, but we may not use it according to the spectroscopy libraries. And the most optimal approach regarding the molecular change, this is the ITR-FTR spectroscopy, which is the most common used one, which is the most used one, where we have the internal reflection element and detector, which are used in between the crystal. And the only downside is that we need to move from the wavelengths to 650 centimeters, reverse centimeters. And this is the limit which is connected with the focus lenses and with the transparent materials which are being used. But the practice has shown us that the real border is 500 of possible centimeters, because the more intensive wavelengths might not be present. The analysis of all concrements of Dnipro region were performed by using this complex OMNIAC FTIR-10, and which was used by thermoscientific nuclide. And the FTR diamond crystal attachments were used by Spicak company. Sample a powder in the center of the circle. And we also used the OMNIC FTIR software and spectral library Nicodome and kidney stones, which have 1,668 spectrums. As in the whole world, most of the kidneys, 48%, they are oxalates. And also 43%, they have the oxalate containing mixed types. Phosphate and uric acid are just like 5%. And the registered spectrum actually shows us a great match with the library samples. The overall correlation is around 82%, because during the sampling analysis, there was a more noisy signal, but noisy signal does not influence the accuracy of the identification, and that is shown over here on the histogram, where we have in the center 84%. And over here, the match shows us that 55% of complements have a half quantitative structure. ITR-FTR spectra of conditional pure oxalates, phosphate, and urate stones, they have shown us over here that the length is less than 800 reverse centimeters, and they are more fulfilled with these peaks. But the maximum of those peaks, they differ, but in general, they are going to overlay, which potentially might lead to the issue with identification. So over here, those lines might show us the presence of additives or some additional structures, and we need to have additional analysis of the spectrum lines over here. Let's give an example of error in automatic identification of the stone spectrum using the Nicodome database, which is the library. And it has shown a maximum match with vandelites in the same proportions. But when we compare those curves, we show that this painted structure, it was not that important as, for example, the diffusion of protons, 2,700 reverse centimeters. So that is something which is more specific for urate. And only on the 8th place, we have the stone, which was having the same spectrum. The possibilities of this software and technical complex, it just does not limit itself to the FTIR microscopy. We might see the microimage of the polished surface. That is something which is going to allow us to have a polished surface of a kidney stone corresponding UFTR map of the distribution, and gives us the possibility to have a better understanding of the different organic structures. And you may see over here also the corresponding UFTR map of the distribution of organic CH groups. And you may see over there the red, which is high, the blue, which is low. From our point of view, there are two ways how exactly we may use this approach of FTIR spectroscopy. First of all, to implement the quantitative analysis. We may use some additional methods, or we may use some additional ways to identify the additional structures. The respective usage of microanalysis in terms of the different structures, it also gives us the idea to identify the primary and secondary chemical structures, which might lead us to a better understanding of those physical processes and to identify better pathogenesis. And the second scene, we know that most of the concrements with the size less than 10 millimeters, they spontaneously have a passage. And by using this spectrometry analysis, we may identify, that starting from the 1 millimeter of diameter, the leftovers. And it gives us a better understanding of those predictors which lead to the formation of the concrements, and then to use the inhibitors in order to prevent the development of the recurrent urolithiasis. And we may use those minerals which are going to be analyzed by FTIR microscopy. So we need to have and to identify the way how we concentrate the urine without the loss of all of those minerals. So that is needed for the personal treatment and in order to prevent the recurrences among the patients with the chronic urolithiasis. Thanks a lot for your attention.
Так. Дякую, Олександре Константинович.
Thanks a lot, Alexander. So we have understood out of this topic that this approach is rather complicated, but is rather important. And it is also important to have an access to this approach when we evaluate the composition of the stones, which is something which is recommended by the Association of Urologists of Europe. And also, we need to use that approach more and more for more patients. Right now, we are going to move forward to our next topic, which is a rather non-standard topic. And I would like to invite Maxim Pavlenko, Director of IRIMI Group and also the Deputy Head of the Medical Plaza Dnipro. Please, Maxim, giving you the floor. Thanks a lot, Professor. So, dear colleagues, we'd like to thank you for participating in our webinar. We would like for you to pay attention to the existing approaches to the treatment of urolithiasis. Why at this moment of time this topic is extremely actual. Starting from the beginning of the war, Dnipro is the city which is the first line city, and we have a lot of people which were fleeing. And of course, there were quite a lot of hospitals which were reprofiled for military people. And that leads to a huge amount of the patients which were coming to our clinic as well. We have a rather high amount of patients with the urolithiasis, the increased incidence of urolithiasis, because in the military zones, this is an endemic regions for the urolithiasis. Luhansk, Donetsk regions, Kherson region. And our clinic has all the options in order to provide the specialized care to patients with different kind of profiles, surgery, orthopedics, urology, oncology, and so on. Right now, we have a new surgery block, which is being developed according to the European Union requirements. And they started to act starting from May, and we had enough time to prepare all of that. We have specialists of the high level. And in our work, we use Da Vinci, the innovative system of autopilot Escolab, in order to perform the surgeries in the joints. We have the Karl Storz laparoscopic equipment, and we have a great laboratory. We have CT, and so on and so on. But it's still not enough to provide care to the challenges which we have in the current time in order for us to move forward. I'd like to pay your attention that the complexes and scientific approaches, they're important for all patients, especially for those patients which are fighting right now. Why exactly now? It is the time when we need to do it, when we need to discuss it, because we have a lot of patients. We do have 2-3 times more patients than we usually have. We know that quite a lot of discoveries are done in the stress period of time, and that's why to solve the issue of the urolithiasis, we have addressed to the questions and to the experts from different fields of medicine. We hope that the results of our webinar is going to be the contribution into our victory. All of those scientists and all of those scientific developments we perform with the tight cooperation with the Department of Healthcare, with military specialists, and with our university in Dnipro City.
Thanks to help of colleagues from other countries, we feel supported in the face of Russian aggression. Thus, we will like members of one big family of the free world. This is very important for our patients, our doctors, and our country. Here, I'd like to thank the government and people of Great Britain for supporting Ukraine, especially for allowing anti-tank missiles, thanks to which in the first week of the war, we could resist an aggression, and now we have the opportunity to talk about the complex treatment of kidney stone disease. Glory to Armed Force of Ukraine, glory to Ukraine, glory to the free world. Thank you for your attention.
Дякую, Максим Віталійович. Такий доволі енергетична
Thanks a lot,
доповідь.
Maxim. That was a rather energetic couple of words, so thanks a lot for that. It was something which energized us, and that's good that we may understand that we may help our patients, or at least to try to help in the biggest possible option. Yes, dear professor, that's something that we need to do, and that's the requirement from us. And that's the time to do something. In case we are going to do it right, in case we are going to have all of our efforts, and in case we would be able to help in the way that it should be, then we are going to have the victory. And could you tell us then, what kind of message would you like to deliver to all of our physicians which are facing not only the urolithiasis, or which in general are facing different kind of diseases, which work with military officers and with internally displaced people, IDPs and so on? Hey, what kind of message? We need to do it correct. We need to do it in time. And we need to do so our work and our contribution, that's to do it quick and to do it correct, to do it right. And then our results of our work, that's something that is going to be that moves our country forward, which helps us to fight the aggressor. Thanks a lot, Maxim. I think that you have written something that is written over there under the urine group. Nothing extra, only the best. Nothing extra, only the best. As it should be. Thanks a lot. Thanks a lot. And we are going to continue. Yes, please.
Шановні колеги, дякую вам за
Dear
увагу.
colleagues, thanks a lot for your attention. And we did not have any questions at this moment of time in our chat. And I hope that in case those questions are going to appear, they're going to be sent to our speakers by us, and you're going to have a personal answer to all of your questions. At this moment of time, I would like to summarize the results of our webinar. So we are fighting and we are focusing on the two important things. So first of all, we were focusing on the providing care to the military services, military officers. And Professor Golovko has proven us the information which is extremely important, which is important at this moment of time, which is important in the process of evacuation of our patients. And we do understand that in case we are going to have the in-time diagnostics, we would be able to evaluate the state of the patients, and then the patients might stay in the military hospitals near the battlefield. And those patients which do have complications, they might get in time into the hospitals, tertiary hospitals. And that's rather interesting as well, that we have the ultrasound diagnostics machine which is used. I am communicating a lot with the head of the medical care in the battlefields, and they have shown how exactly it works. And we know that for the diagnostics of the urolithiasis, ultrasound is taking the first place. So the topic of Maxim, who has just delivered a couple of words before me, this is the person who is an energizer. That's just, you know, an engine. That's an engine of any kind of project. And in case you work just nearby him, then on an everyday basis, you need to do something because there are constantly questions. Have we done this? Have we moved forward with this one? And do we have a scientific value of that point of view? So thanks a lot, Maxim, for this kind of everyday care. And thanks a lot for putting his contribution. Konstantin Baranik was delivering an interesting topic. He has performed this kind of bridge between the clinic and diagnostics. So we were talking about the recommendations which we may read. So there were some guidelines which were mentioned in the Association of Urologists. And we need to understand that everything that is written there, it should be implemented when we work with our patients. And also we need to look forward in order to use or to try to use all capabilities of today and all the future technologies. Harry Whitwell, thanks a lot as well for this interesting topic and interesting lecture regarding the proteomics. Proteomics, that's something which is extremely interesting for our patients, especially. And we do understand that this is a new technology which is not yet implemented and which costs a lot, but I do believe that step by step, our cooperation in this sphere is going to lead to the point where mass spectrography, this proteomics analysis, is going to be implemented in everyday practice. Oleg Blus, great topic. I would like to emphasize once again that's a real state-of-art lecture, which might be used as a guideline, not only for beginners, not only for those who just start to make their first steps in the statistics, but also for experienced specialists, which want to achieve some great results in this sphere. Associate Professor Ishkov Valery has shown has shown us some data about the crystals and has opened the world of crystals for us. And it was rather understandable for us why different stones behave differently depending on the structure and depending on how exactly they react to those approaches which we use to destroy them. And finally, Professor Balai has proven and has shown us some specific issues by using the infrared spectrometry and how important this approach is to evaluate the quantitative and the qualitative structure of the stone, which gives us some potential to perform the correct treatment of those patients. I would like to emphasize that we have invited different specialists because exactly the different view from chemists, biochemists, statistics specialists, it is something that might ensure the breakthrough in terms of the treatment prevention and strategies regarding the urolithiasis. I would like to say thanks to the Dnipro National Medical University for organizational and scientific support and cooperation with us. Department of Healthcare of Dnipro region for practical support and for cooperation to work further and to move forward. Especially I would like to say thanks to our colleagues from UK, which provide us data, about the new technologies and which help us to move forward to the future. And we really hope that we are going to have a fruitful cooperation in the future with all of you in the nearest future in order to have all of those new technologies for them to be present in Ukraine and for them to be available in Ukraine. I would like also to say thanks to the Bionorica company, which is a sponsorship company and which sponsors us. And we know that Bionorica is well known thanks to the canifron, which is well used by all urologists in their everyday practice. And I do know that there is no patient who would suffer because of the urolithiasis. They're using canifron. Canifron has different stages, and it covers a couple of stages of pathogenesis. And that's why canifron is such a widely used drug. As it was already mentioned, one of the best drugs. And also it is needed to be underlined that Bionorica company, it looks forward not only regarding their own drug in order to support the implementation of this drug, but also Bionorica is looking forward towards to develop the correct practices regarding the treatment of the urolithiasis in Ukraine. We would like to say thanks to Karl Storz company. For a long period of time, we are familiar with this great company. And I would like to say that for at least 15 years, we know each other. And I would like to say that this is really the company which has made everything in a state-of-art way, starting from our today's broadcast or finalizing our today's broadcast, support during the treatment of our patients. We know exactly that great equipment which we use by Karl Storz, endoscopic equipment, and quite a lot of things around that endoscopic equipment. They constantly support us. And in case we talk about the laparoscopy and endoscopy ways of intervention, I work in the endoscopy for more than 10 years. And there was no moment of time where Karl Storz equipment was not working properly. In case some kind of cases or events happen, we have support from them. So I would like to recommend that company. And finally, that company fully supports all of those scientific events, and that is something which is just great. Also, I would like to say thanks to Medical Plaza and IRIMI Group for organizing this platform to have this webinar. And of course, I would like to say thanks to the designers, Kovalenko and Mobster's team, which have provided us this great demonstrational materials.
Сьогодні, коли Україна
So today, when Ukraine is getting through this severe period of time, our guys which are fighting in the battlefield, they make us closer to the victory. Everybody has to have their contribution. Our main demand is not to stop providing care to the medical care to people and to the population. And that's our way of support. And that is something which is needed as the background of our free country in the future. Glory to Ukraine, glory to the armed forces of Ukraine. Thanks everybody who was participating in this webinar. Thanks a lot, everybody.
Запорукою у лікуванні сечокам'яної хвороби є досвід професіоналів та правильно підібрана терапія. Фітопрепарат Канефрон Н Біоноріка Німеччина є одним з дієвих засобів рослинного походження, що застосовується у лікуванні сечокам'яної хвороби. Рослинні компоненти Канефрон Н вирощуються у контрольованих стандартизованих умовах. Всі етапи та методи виробничого процесу обґрунтовані аналітичними розрахунками і являють собою складну систему, що поєднує природу і науку. Канефрон здатен комплексно впливати на неспецифічні фактори каменеутворення. Доведено сприяє зниженню концентрації основних каменеутворюючих субстанцій – солей сечової кислоти на 23,5% за 3 місяці та оксалатів сечі на 19,5% вже за перший місяць застосування. Прийом рослинного препарату протягом 1 місяця сприяє підвищенню концентрації іонів магнію, основного природного інгібітора кристалізації сечі, на 16,5%. В результаті Канефрон Н пригнічує патологічну кристалізацію сечі. Активні речовини у складі фітопрепарату володіють протизапальними властивостями, а також сприяють підвищенню рівня добового діурезу і зміні pH сечі до фізіологічно оптимальних показників, що дозволяє попередити рецидиву утворення конкрементів. Багаторічний досвід застосування канефрону доводить його ефективність в комплексній терапії, тому Канефрон Н доцільно застосовувати при різних видах конкрементів, після операційних втручань по видаленню каменів, для метофілактики, для лікування супутніх мікробно-запальних процесів сечових шляхів. Тому канефрон може покращити ваш успіх в лікуванні сечокам'яної хвороби.